Good morning, and thank you for your time and listening to me in this webinar, in which I would like to explain the role of immunonutrition in surgical cancer patients. One of the major data that I can show you today is the fact that surgery is one of the most frequent medical procedures. These are recent data coming from the UK, and you see that in the UK, in the period from 2010 to 2014, there have been more than 7 million surgical procedure, invasive surgical procedures. So surgery is really one of the most frequently used medical treatment. What about the efficacy? Well, you see again that the mortality, particularly for the restrictive, which means the more invasive surgical procedures, is slightly going down. But the frequency of the procedures, and particularly for the less invasive, is really going up, more than 7.5 million in the period in 2013-2014. Why is this happening? Why surgery is becoming more and more frequently used by MDs all over the world? For a number, of course, of reasons, but most importantly because most of the more invasive surgical procedures are done in cancer patients. And we know that cancer is a disease whose prevalence is increasing. Let me give you an example. These are very recent data coming from the US. You see here that the good news is that the mortality is really going down during the last 40 years. You see also during the last approximately 100 years. But you see that the incidence of cancer in the US is actually going up. It is stabilized, but it seems that it's not really going down to the level, for example, in the 1975. The most striking evidence, it is at the bottom of this slide. And you see here that, again, based on US statistics, the probability of developing invasive cancer for US citizens from birth to death is approximately 40%. So everyone who was born now in the US has 40% chances of developing an invasive cancer during his or her lifetime, which means that we expect a number of patients really in need of surgical procedures. But how surgical procedures stands in the general management of a cancer patient? Well, actually, let me give you some example. Let's say that a patient is diagnosed with cancer. At this time, he has two options. Option one, he's diagnosed with an early cancer. So the doctor sends him to the surgeon who removes the cancer, and the patient is more or less cured. Unfortunately, many cancer patients are diagnosed with advanced cancer, and the patient then has two options. Start the so-called disease-modifying therapy, which is aiming at the cancer cells, and it is, of course, chemo, radio, and of course, surgery. But also it has palliative care. Palliative care is all the care which is given not to the cancer cells, of course, but actually to the patient, to support the patients. And the goal of disease-modifying therapy, of course, is to improve survival. And the goal of supportive care, palliative care, is to actually improve quality of life. However, and this has been now demonstrated many times, that when a cancer patient receives simultaneously disease-modifying therapy, like surgery, and supportive therapy, like, for example, nutrition, the survival is improved. So it is very much important that even during surgical procedures, the importance of palliative care or supportive care, like nutrition, is actually recognized and provided to the patient. So surgery remains a key disease-modifying treatment and will remain a key disease-modifying treatment for cancer patients. But which is the goal of surgery, of any surgical procedure? Well, of course, we have a couple of possibilities. Surgery, of course, has an immediate outcome, which could be survival. which could be reduction of postoperative complications, discharge time, cost reduction, quality of life. But we always have to remember that the patient who undergoes surgery is in need or to receive also some long-term outcomes, like survival, return to work, and the possibility, for example, to start chemotherapy. Now, are there any prognostic factor which influence the outcome? Of course, yes. For example, the surgeon's skill. If you are, taken care by a less prepared surgeon, it is likely that his surgical procedure would not be very effective. But also the number of surgical treatments performed in that specific center. Now, it is very well known that the risk of complication is reduced in those centers in which many surgical procedures, specific surgical procedures are done. And of course, also the clinical conditions of the patients, the comorbidities, but also the nutritional status is really important as a prognostic factor for an effective surgical procedure. Now, what I really would like to highlight is the fact that among all of these prognostic factors, which I mentioned here, only one is modifiable, which is nutritional status. You cannot change the surgeon's skill. You cannot change the number of surgical treatments performed in a center. You cannot actually change, or you can modify, of course, clinical conditions, but you cannot do it in an emergency procedure. Comorbidities are not modifiable, but nutritional status is modifiable. And we know very well that the clinical journey of a cancer patient, particularly a patient with advanced cancer, is associated with a number of so-called catabolic crises. If we imagine the progression or the behavior of body weight loss in a cancer patient, we know that there are the catabolic crises which are associated with some kind of interventions like chemotherapy, like surgery, adjuvant therapy. And we know that this important treatment is associated with an impairment of nutritional status. And of course, a cancer patient should receive an acute intervention, a specific intervention during the catabolic crisis like chemotherapy or surgery, but these should be coupled by a chronic intervention. So the patient should know what he has to eat, which is the target for his body weight from the diagnosis until the end of his clinical journey. So which is the role of nutritional support in surgical cancer patients? Basically, we have two major outcomes, two major goals for nutritional support, which is to substitute and to prepare. Let's start with substitute. Well, we know that many surgical procedures, particularly the most invasive surgical procedures, are associated with a significant decline of spontaneous food intake, which may even worsen the poor nutritional status which at baseline is shown by any cancer patient. So you see very well that, for example, in the recent ESPEN guidelines for nutrition support in surgical patients, we have many recommendations saying that nutritional support, and particularly oral nutrition with supplements or enteral feeding, should be initiated very early in the patient in whom early oral nutrition cannot be started, or in whom oral intake will be inadequate for more than 7 days. So there is absolutely no doubt that nutrition should be started for those patients who are malnourished, who are at risk of becoming malnourished because of the surgical procedure. And we have data showing that this is effective. This is an interesting study recently published with showing that the patients who were receiving perioperatively oral nutritional supplement had a better, you see here, a better preservation of skeletal muscle index after 3 months after surgery. And you see that the sarcopenia prevalence is significantly reduced in those patients who were receiving perioperatively oral nutritional supplements. What is important in this study is the fact that the authors were also looking at what's going to happen to the patients when they were receiving chemotherapy. And I just want to highlight that the patients who were receiving oral nutritional supplements in the perioperative period, there were less chemotherapy modifications such as dose reduction, delay, or termination, which means that what the surgeon is doing in the perioperative period will have an impact not only in the immediate postoperative period, but definitely months after the surgical procedure. This is very important that surgeons keep in mind. This is another interesting study. Again, patients receiving pre-operatively oral nutritional supplements. So there was a significant increase in the energy intake and the protein intake. And this was associated with a significant reduction of postoperative infections. And again, in the multivariate analysis, you see here that the use of oral nutritional supplements was actually one of the few significant influencing factor reducing the infections after surgery. But so far, we have been speaking about only calories and proteins in general, not with specific nutrients. We know very well that the quality, particularly of the nitrogen content of oral nutritional supplements or enteral feeding, could be quite different. And we can also use amino acids or nutrients which have a significant impact on an immune function. This is again a recent study, a retrospective study, showing that the patients received, there were this kind of patient with low skeletal muscle index or high skeletal muscle index. And you see here that the patients with low skeletal muscle index had a significant increase, for example, of intra-abdominal abscess. But the use of immunonutrition in these patients was significantly associated with improvement in infectious complications. This is very interesting because it shows that in a patient in whom we have a significant deterioration of the nutritional status, particularly a reduction of muscle mass, the use of specific supplements, specific formula, including immune-enhancing nutrients, is associated with an improvement in clinical outcome. Not only that, this is again another study showing that the patients were receiving an immunonutrition had a better outcome in terms of infection when compared to the standard oral nutritional supplements. So it really seems that the use of specific formula, which includes nutrients, which with significantly and reportedly effects on immune functions, including arginine, omega-3 fatty acids, or even glutamine, this is associated with an improvement in clinical outcome, like, for example, the infections or the need of changes in therapeutic antibiotics. Because of these evidence, of course, some meta-analysis have been produced, and again, in surgical patients, this is a recent review which has been published in British Journal of Surgery Open. It shows that the use of immunonutrition is superior to the control in terms of the prevention of infectious complications. You see here that the reduction is approximately 40%. Of course, there is also an improvement of approximately 35% in the surgical site infection when you compare immune nutrition versus control. But there is actually no significant improvement in 30-day mortality in immunonutrition when compared to control. So at this time, we can say that there are emerging evidence showing that at least in specific cancer surgical patients, the use of immunonutrition is associated with a significant improvement in clinical outcome, particularly infectious complications, when compared to the standard supplement and control for this category of surgical cancer patients. Because of that, of course, international guidelines have included immunonutrition in their recommendations. This is a recommendation from the ERA Society for Perioperative Care in gynecologic oncologic patients, and the recent update, the 2009 update, actually include new information on the role of immunonutrition, the positive, the beneficial effects of immunonutrition. Not only in gynecological patient, this is the results published a few years ago about the use of perioperative immune nutrition in patients with colorectal cancer undergoing surgery. And again, you see here that the patients with perioperative immunonutrition had a significant reduction in the percentage with any complication. Particularly, you see here, infectious complications, surgical site infection, superficial and deep incisional. So it really seems that the use of immunonutrition may help in the immediate postoperative period the patients to face and to resist to infectious complications. And again, also the ESPEN guideline published in 2017 actually suggests that the peri or at least postoperative administration specific formula should be given in malnourished patients undergoing major cancer surgery. But I think that this is only part of the potential role of immunonutrition in surgical cancer patients. Because one of the major limitations of all the studies showing or testing the efficacy, the clinical efficacy of immunonutrition in surgical cancer patients is the fact that the follow-up period was 30 days, 45 days. So very, very little of them, very, very few of them actually extended the follow-up period over the long period, which is extremely important because modulation of the immune function during the perioperative period may not only help the patients to resist to infections in the immediate postoperative period, but may also influence the metabolic milieu and the inflammatory milieu of the cancer cells. And in turn, this could be effective in improving the long-term outcome of these patients. That is why I'm saying that particularly immunonutrition is important, not only to substitute what the patient is not able to eat, but also to metabolically prepare the patient. And of course, it is important that we focus on long-term outcome. We already show that immunonutrition is effective in the immediate outcome. But what about the long-term outcome, meaning months after the surgical procedures? Well, first of all, we have to remember that any cancer patient shows a disruption of the immune function. One of the most important aspects is the ability of cancer cell, you know that, to evade the immune response, the so-called tumor immune evasion. And this is mainly based on, for example, on the increase of the T lymphocyte regulatory, the Treg cells, which of course are associated with immunosuppression, which helps the tumor cells to grow without being stopped by the immune system. And these changes in the immune system is actually shared not only by cancer, but also in patients with aging, and of course in patients with sepsis. Just to give you very briefly, I will not go into the detail of the molecular mechanism, but you have to imagine that the tumor cell is able to produce a number of factors which may directly inhibit the efficacy of the effector T cells, or may also block these effector T cells by a number of other cells, like for example the tumor-associated macrophages or the T regulatory cells. which in turn block the effector T cell. So in the healthy situation, there is a good balance between T regulatory cells and the inflammatory immune cells. When the inflammatory immune cells have the prevalence, you have an increased risk of developing autoimmunity. Unfortunately, when you have an increase in T regulatory cells, the risk of developing cancer is insignificantly increased. Now the question is, we know now that we can interfere with these mechanisms by a number of drugs. But is it possible to influence these pathways also by nutrients? Well, of course, yes. It has been now demonstrated that the use of specific nutrients like fatty acids or arginine or glucose or glutamine, you can influence all the different types of inflammatory immune cells which are involved in the immune control of the tumor growth. And the importance of these supportive care, which of course include nutrition, is being recognized. And because of COVID-19 pandemic, now surgeons recognize the importance of supportive care, palliative care. For many, many years, the surgeons were just operating, not really taking care of what was happening 7 days before surgery or 7 days after surgery. But because now, because of the pandemic, it is becoming more and more important to really bring to the table those patients who will actually get the most benefit from surgical procedures. The surgeons must embrace palliative care. And this is just a viewpoint which has been published at the end of April this year in JAMA Surgery, highlighting the importance that even surgical patients, the support to the patient, rather than actually the technique of removing the cancer cells, is becoming very, very important. So the key question right now is, can immunonutrition favorably influence the immune milieu in surgical cancer patients? And because of that, of course, you can significantly improve the outcome of these patients. First of all, we now know, and it has been repeatedly demonstrated, that the perioperative period is a key period during which we can improve the long-term cancer outcomes by affecting perioperative factors, by reducing the neuroendocrine and paracrine production, by modulating immune factors, and of course also androgenic growth factors, we have the possibility to actually reduce the progression of tumor growth. So again, what is not done in the perioperative period in a surgical cancer patients, unfortunately, will have an immediate impact on perioperative complication, but unfortunately, it will have a negative impact also in the long-term outcome of these patients. And in this very nice review paper published a few years ago in Nature Review Clinical Oncology, it is highlighted that omega-3 fatty acids may have actually a potential beneficial effect in the long-term cancer outcome, has been demonstrated in many animal models, but we still have inconsistent evidence in human, and we need to provide more randomized controlled trials. First of all, which are these inconsistent evidence? First of all, okay, this is an interesting study published this year. These are patients, these are not actually cancer patients, these are patients undergoing cardiac surgery. And you see here that the possibility of use immunonutrition is associated with an improvement, for example, of CD3 cells, and more importantly, of CD4 cells. So definitely it is possible by immunonutrition to influence the circulating levels of important lymphocytes, which can help actually the fight against the residual cancer cells after surgery. So theoretically, And practically and pragmatically, using immunonutrition will have positive effects on nutritional outcomes, but also will have positive effects also on the different classes of immune cells. As you can see here, indeed, the same study showing that it is because of the immune nutrients, which actually it has the positive effects on the changes in CD3 and CD4 T cells. So really you can do that. But more than circulating cancer cells, it is important to see what happens in the tumor burden. Increasing the number of circulating CD3 and CD4 cells is important, but what can really make a difference is changing the inflammatory microenvironment of the tumor. We know that the tumor which is removed from the abdomen of a cancer patient, for example, is not only cancer cells. It is stromal cells, it is inflammatory cells, it is nerves, it is bacteria. And we know that by changing the composition of immune cells within the tumor will have a significant effect, a positive effect on the long-term outcome of the cancer patients. So the idea of this pilot study, which we did because of the MD thesis of Dr. Palladino, was to see whether the use of immunonutrition versus control and versus placebo was associated with an improvement or a change in the number of specific lymphocytes within the tumor. And this is an interesting study. This is an intratumoral CD4. You see that this is a section of the tumor removed, the gastric tumor removed from a cancer patient, not receiving any kind of supplementation pre-operatively. These patients were receiving a standard oral nutritional supplement, and this patient here was receiving immunonutrition for 5 days before surgery. And you saw that there is a significant reduction in the count of CD4. And we know that the more CD4 intratumoral, this is associated with a better cancer progression. So we can speculate that patients receiving immunonutrition will have a reduction in CD4 cells in the tumor, which is associated with a better outcome. Not only that, we were also looking at the CD8 cytotoxic. And again, you see here the tumor, the gastric cancer of the patient not receiving any kind of supplementation. This patient was receiving a standard oral nutritional supplement before surgery, and this patient here was receiving immunonutrition before surgery. And again, you see the dramatic increase in cytotoxic CD8 cells within the tumor. And we know that this is associated with a better outcome. Of course, we were not able, because of the limited number of patients, we were not able actually to check whether there was an improvement in survival. Oh, of course, we were looking at that, but it's useless to mention this because the study was not powered to detect any improvement in survival. But we can speculate that patients whose tumor had a reduction in CD4 and an increase in CD8 cells had a better outcome after 6 months or even 1 year. Indeed, there is a study in which the impact of immunonutrition on survival of cancer patients was done. And this is the Kaplan-Meier for progression-free survival and overall survival. And you see that these curves are quite different. And it seems that the patients who were receiving perioperatively the immunonutrition had a better progression-free survival and a better overall survival when compared to patients receiving a standard oral nutritional supplement. However, these differences are not statistically significant. More importantly, the study was not powered to detect any change in survival. So we really need to start a randomized controlled trial, or maybe we can look back at the database that we have in our hospitals to see whether the patients who were receiving perioperatively immunonutrition had a better outcome after 6 months or 1 year or 2 years, just to provide the definite answer to the question whether immunonutrition can improve the inflammatory milieu of the tumor and consequently have a better outcome after 6 months or 1 year or 2 years. Of great interest is this recent review paper published in Nature Review Cancer, clearly showing that the mechanism associated with cancer progression, metastatic progression, are similar to those used for cachexia. It is therefore tempting to speculate that if we are able to improve the nutritional status of our patients, if we are able to improve the immune function of our patients undergoing surgery because of cancer, then we can also have a significant improvement in the progression of the cancer and to the metastatic phases. So it really seems that nutrition can provide definitely the substrates to help and to foster recovery from surgery, but also can metabolically prepare the patient to fight better the remaining cancer cells after surgery. So in conclusions, we know that cancer mortality is declining in most world countries, but unfortunately the prevalence is also increasing. And the benefit of anti-cancer treatments, and here I'm talking about chemotherapy and radiotherapy, appear limited for patients with advanced disease. Surgery will remain a key player in the fight against the cancer. And nutrition in these patients can replenish nutritional deficits. And this is associated, this has been demonstrated, to improve, to yield to improve immediate post-operative outcome. Unfortunately, in cancer, we know that tumor growth is associated with impaired immune function. And this is one of the reasons why the tumor can help, because these impaired immune functions lead to the so-called tumor immune evasion. There are now consistent evidence that specific nutrients, including omega-3 fatty acids, arginine, glutamine, can modulate the immune function. And this may restore the immune competence in cancer patients. And also, it is very much interesting that emerging data now suggest that immunonutrition may moderate immune response, but also ameliorate inflammatory tumor microenvironment, which can in turn possibly enhance the long-term outcome of these patients. So the main message today is that what is done in the perioperative period in terms of nutrition can have the immediate postoperative outcome, but also can give more chances to the patient to get benefit of the subsequent treatments. And of course, what is not done today will reduce the chances of the cancer patients to benefit of anti-cancer treatments. Thank you very much for your attention, and of course, send in your questions and I will be more than pleased to answer your questions. Thank you again.